Alrighty, welcome back, folks. So we're still in session 1 here today at the 3rd annual IDOHDAY. And hope you all enjoyed the light refreshments for the coffee break. So next up, carrying on the theme of integrating the social sciences and new technologies into the overarching concept of One Health, we lean back more into the social sciences, looking at access and how people interact with our different healthcare systems, particularly in non-endemic countries. So please join me in welcoming to the stage our next speaker, Iglesias.
So good morning. It's a pleasure to be here and share with you part of my thesis. As you may know, Chagas disease is a parasitical chronic infection caused by Trypanosoma cruzi, and it's considered by World Health Organization as a neglected tropical disease. Triatomine insects are the main transmission route in endemic countries, whereas blood transfusions, solid organ transplants, and congenital transmission are the main routes in non-endemic countries. I will focus on chronic phase because it's the most frequent phase in non-endemic countries. 70% of cases remain asymptomatic, while others will develop digestive, cardiac, and neurological damage. During this phase, diagnosis need indirect methods, such as ELISA, which has high sensitivity and specificity. Regarding treatment for Chagas disease, it has 2 available drugs, benznidazole and nifortimux, both with side effects and limited access. His benefits are reduces vertical transmission. It's useful in congenital infected newborns, acute phase and reactivation of the infection, and in chronic phase in people under 18. However, it's not as useful in terminal chronic phase or people with visceral involvement. What can we say about Chagas epidemiology? From 6 to 7 million people worldwide are infected with the parasite, and it's endemic in 21 continental Latin American countries, usually present in rural areas of Central and South America. However, migration, mobility, transmission routes have enabled this spread to non-endemic regions. In Europe, it's estimated that there are 68,000, 120,000 cases, and the highest burden of the disease is borne by Bolivian population. Particularly in Spain, it's the European country with highest burden of Chagas disease, and 81% of cases are from Bolivia. What can we say about economic impact of Chagas disease? Well, Chagas produces premature death, which sometimes ruins migrants' life project, and also causes a productivity decline, disability, and high cost to healthcare systems. Well, what have we done in Spain with our strategies to control Chagas disease? Well, when we decided to carry out this study, there were a law ensuring safe blood and organ donation since 2005, and there were some regions that had some solid protocols for screening pregnant women. But in fact, in the community of Madrid, there were only few recommendations, but not a solid protocol. These facts confront with World Health Organization recommendations because they recommend an early access to diagnosis. Then there are several theories and models to explain access, but we used Anderson behavioral model because it can explain health behavior with social sciences, which is in line with One Health proposal. The reason why we decided to carry out this project was the underdiagnosis from 96% in Europe, and taking into account the chronic complication of Chagas disease and the efficacy of treatment in early diagnosis, well, it was necessary to carry out this study. So the main objectives were to identify factors that enable or hinder access to Chagas diagnosis in Madrid, and specifically to explore factors that influence Bolivian populations' health behavior in relation to Chagas diagnosis, and to explore knowledge, attitudes, and practices among primary health care professionals. So the setting of our study is in Madrid City, and according to municipal census in 2017, there were 19,951 people born in Bolivia, from which 9,193 were women and 6,758 were men. Healthcare in Spain is free because of our national health system, but some restrictions apply to undocumented migrants in 2012 and 2018. Healthcare is provided through primary care and hospital care. My thesis is part of a project titled Accessibility and Health Service Use for Diagnosis and Treatment of Chagas Disease in Madrid, and it's run by the National Center of Tropical Medicine. It's a mixed method study. On one hand, quantitative research with a cross-sectional study survey about health-seeking behavior, and on the other hand, qualitative research performed with Bolivian population over 18 years of age and who have their residence in Madrid. Healthcare professionals, physicians and nurses, and key informants. The main data collection techniques were triangular group, focus group, semi-structured interviews, and no participant observation. We also recorded some socio-demographic variables for Bolivian population, primary care professionals, and key informants. So the places for data collection were primary care health centers, tropical medicine units, the Bolivian consulate, and those places which make the participants feel comfortable, for example, their houses. The digital recorders were used to collect data, and audio files were transcribed by an external expert and subject to quality control. An inductive data analysis was performed by two researchers according to grounding theory using MaxQDA 18 and ADOHDAY software. This study meets the criteria of research trustworthiness set by Lincoln and Guba because we did a continuous field work and data collection and analysis were simultaneous. Moreover, and data sources and analysis triangulations were performed, and we also described properly setting and participants' profiles. Moreover, data topic guide and analysis were properly recorded and documented. Regarding ethics approval and consent to participate, our study and its protocol were approved by Research Ethics Committee, and written informed consent on personal data were managed in accordance with Spanish law. So next, I will show you some information in relation with the characteristics of our study population. With respect to Bolivian population, 79% of our sample were women between 28 and 59 years old, and 92% of this population had at least one child. And their average time living in Spain was 10 years. Regarding healthcare professionals, 75% of the sample were women, and we tried to perform the focus groups on those districts with highest volume or Bolivian population, and we decided also to perform the focus groups on those districts with little Bolivian population in order to explore the differences between their speech. Regarding key informants, we interview a journalist, two health agents, and a health program coordinator. Okay, on the next slides, I will tell you some information about our results and discussion. Regarding the factors that influence Bolivian population's health behavior in relation to Chagas diagnosis, it's the first time that we use Andersen's model to explain Chagas disease diagnosis. And we add some additional factors related with stigma and shame, family history, symptoms, and attitudes. People interviewed told us that having a relative sick or disease from Chagas disease, and for men, having a pregnant wife with a positive result, were big reasons to getting diagnosed. They also valued positively if a family or a friend advised them to getting diagnosed. There is a discourse in this population that they do not identify themselves as possible bearers of the parasite because they don't live in those endemic contexts. So this makes them feel invulnerable, right? So it's a very dangerous discourse in non-endemic contexts. Moreover, stigma is perceived in different ways if there was women or men. For men, they don't want to be identified as poor peasants or people from rural environments, so they avoid getting diagnosed for these reasons. And women are afraid of being rejected by Spanish population, and its possible consequences such as job loss or social isolation. Moreover, people interviewed have the idea that Chagas has no cure, and it's strongly associated with death, so it makes no sense to be diagnosed with a deadly disease. And they think that if they know they bear the parasite, it could deteriorate their health. About the symptoms, they thought that no symptoms means no disease. And if there are symptoms, maybe they associate this with their lifestyle, the immigration lifestyle, or maybe they could think about their family or personal history, so they decided to get diagnosed. With respect to the knowledge, attitudes, and practices among primary healthcare professionals, this is the first time we use qualitative research to give an explanation to this issue. 5 themes emerge according to the healthcare attention process: knowledge about Chagas disease, professional opinions about patients' community knowledge and attitude, attitudes of primary care professionals in identifying factors for serologic testing, practices on testing and treatment, and patient care and follow-up circuits. Regarding knowledge about Chagas disease, physicians have some doubts about the test availability in their context, and if there were any symptoms that make them think about the request of the serology. About the treatment, they also think there is no cure for Chagas disease, and if there is any treatment, they couldn't prescribe it. And about the transmissions, the transmission, both physicians and nurses thought that the vector is the main way of transmission. So they don't think about the vertical transmission or other ways. And it's very dangerous because they are in non-endemic contexts. Regarding professional opinions about patients and community knowledge and attitudes, nurses told us that Chagas is considered as a stigma or as taboo, but physicians thought that it was because of the migration status that linked to the stigma. Okay. However, they conclude that the patients don't talk with them about Chagas disease. Moreover, physicians told us that there were some people who was concerned about the death and Chagas disease, and there were other people that were unconcerned about their health, because, as you know, it has no sense to be concerned about a deadly disease. Okay. Moreover, there was a disagreement about access barriers in diagnosis. Some of the participants told us that the barriers were related to social problems, but others think about them, think that healthcare professionals were not a barrier. But we know they have low knowledge, so they themselves are a barrier for healthcare. Regarding attitudes of primary healthcare professionals in identifying factors and for serologic testing, they consider Latin American population as a homogeneous group, and they identify it by phenotype. It's a risky attitude because not all people from Latin America have the same phenotype. Moreover, they mentioned a healthy immigrant concept, so they concerned about prevalent diseases in Spain, the social problems in Spain, and vaccination status. So it's very dangerous as well. Both physicians and nurses told us that the country of origin is not consistently recorded in their medical history. For example, people with HIV who are from some regions of Africa, there is a flash in the medical history that notifies the need for HIV testing, but it's not as in the case of Chagas. Regarding practices on testing and treatment, both physicians and nurses show a low suspicion of Chagas and told us that there was no norm to request a serologic determination. In the case of vertical transmission, there were some protocols in some hospitals for screening pregnant women, They knew it, but they assumed it was carried out by obstetric service. In some cases, but few cases, some physicians told us that they had found with a patient request. One of the physicians told us this way. She came 2 weeks ago and she told me that her sister had been diagnosed with Chagas disease. She's from Bolivia, so I requested it. She did not come saying, I want the blood test, but something came up. I have this doubt, maybe. Then, regarding patient care and follow-up circuits, family physicians assume a facilitating role because patients with a positive diagnosis are referred to those specialists at hospital, but they admit having a poor participatory role in the follow-up of Chagas disease. They demand little information about this process, and sometimes they have several problems to access clinic history in hospitals. I want to remark that nurses show doubts about their role in the process of attention of Chagas disease. One of the nurses told us that, well, anyway, there is a question that comes to me about all this, and it is, you have this kind of patient, and what would you do as a nurse in those cases? Will be a patient who is some occasion or in some process of his pathology should be referred to nursing. Taking into account that there are chronic damage such as cardiac, digestive, it's a chronic patient, so primary care health nurse have the big opportunity to work with this population. The limitations of our study, well, our findings are not necessarily applicable to other contexts, but it may provide new information that can be used in another non-endemic regions and maybe will replicable. The sample consists of Bolivian individuals with a positive diagnosis. So we do not know the discourse of those people who had in contact with the healthcare system and who have an unknown diagnosis. And I want to remark the reluctance of men to participate in the interviews and the EFGs and the EFGs. We don't know why is the reason, but we think that there is some masculinity, is hegemonic masculinity, so they are afraid of show vulnerable or ill among other men. So maybe they didn't want to talk. So to finish with the conclusions, one, the most relevant facts for the decision to be diagnosed pointed out by participants were having relatives who were sick or diseases from Chagas disease, or for men having their pregnant wife with a positive result. Socioeconomic factors, knowledge, and attitude about Chagas disease, stigma, and healthcare environment facilitate or hinder the decision of being diagnosed and the access to the diagnostic test. And two, the diagnosis of Chagas disease in non-endemic countries continues being an important challenge for health systems. The results obtained with the study of the knowledge, attitudes, and practices of the healthcare professionals and primary care allow us to obtain evidence that could help to develop strategies for the screening of Chagas disease in a protocolized way in order to avoid that the diagnosis depends exclusively on the request of the patient. So that's all. Thank you for your attention. This is a tiny part of my research, so if you want to know more, here is my org sheet and my emails. So thank you so much.
And with that, we'll open the floor to questions. Anyone just raise your hand? Oh, yep, over there.
Hi, I have a question regarding like the interviews, because I have seen in Colombia, for example, and with people that not necessarily have access to healthcare or are not aware of the diseases, when we conduct the interviews, it's better to do it that the interview is conducted by a person that they can feel connected to. That they feel comfortable and that they feel like represented by, so maybe someone from their country or something like that, and especially for men. So that's one part. And do you work also with a social scientist or anthropologist or something like that to better understand those determinants from?
I'm sorry, my English is awful. So could you repeat the question, please?
So, when conducting the interviews, the participants sometimes feel more comfortable answering those questions and also complying more to the treatments or to in general a hospital environment if they are interviewed by a person they can feel represented by, so someone of their community, or that's a first part.
We also used key informants, such as health agents, because sometimes they were also Bolivian. So talking with them, they gave us some additional perspective, because, well, when I interviewed them, they didn't know I was a nurse. And when because maybe they will feel uncomfortable, yes. So it was taken into account in order to collect as the best data possible, the best possible data.
And if you are going to develop like a program or something like that, have you thought of including a person of Bolivian nationality to assess better the problem and to reach better the people that are
well, it's an interesting question. We haven't taken this issue in account, but it would be an interesting initiative.
Thank you.
Thank you.
The patients that are infected, do they have an idea of when they got infected? And is this population, is it a recent event? Are they traveling back and forth between Spain and Bolivia?
Well, in endemic context, sometimes they have heard in the closest family or social environment about the triatomine insects. Some of them lived in those rural buildings, so vinchucas, as they call them. They had contact with them, so they, in any way, they know they may have possible bearers. But in non-endemic countries, it is maybe because it could be information about their parents, information about their pregnant women. They do not talk about it so widely, and if they talk, it's only with people who they are comfortable with. Yes, and about blood and organ donation, they sometimes get a positive when they want to donate blood. Some of them, when they want to donate blood, are indirectly looking for a positive, but they don't want to go to a healthcare center because there are some barriers related with healthcare attention. Now they need to live at least 3 months in Spain to receive medical attention. So blood donation is a way to know their diagnosis.
And do we have any questions from online? Or no? Oh, we have one. Stephanie, yeah.
Okay. Thank you for the presentation. I was wondering, why did you focus on the Bolivian population and not all the Latin American one?
Okay, we focused on Bolivian population because the highest burden of Chagas is in Bolivia. We cannot explain that the things that all those things with Chagas disease are replicable to other contexts, because in Latin America there are different cultures. So we decided to perform only with Bolivian, and it would be replicable with other contexts. But the main reason of performing this with Bolivian, it was because of the very high prevalence.
Oh, yeah, one quick one from Darren.
In terms of the Bolivians living in Spain, I mean, vertical transmission is about 10–15%. Are you seeing anything in Spain where it's going mother to daughter to their daughter? Have we got, entirely vertical transmissions yet in Spain, or has that not been observed?
Well, not maybe mother to daughter, but not the following line. Maybe because the average age of stay in Spain is 10 years, so maybe when they arrived and had children, the protocols were set down. So maybe there did people our healthcare detected the positive, so we treated those women, and the children were born without Chagas. One of the campaigns of Mundo Sano was no children with Chagas, in order to encourage women to get diagnosed, to get healthy children.
And with that, we'll move on, but join me in thanking Dr. Iglesias Ruiz.